The central, there is conjunctival congestion with discharge, watering from the eye. It's a case of viral conjunctivitis. Second picture in the top, you can see there is mucopurulent discharge, case of mucopurulent conjunctivitis. Third picture on the right top, you can see within the pupillary area there is a pearly white opacity. So immediately behind the iris we have the lens, crystalline lens, and any opacity in the lens is known as a cataract. So this is a photograph of a mature cataract. Second picture on the left, you can see it is a case of bacterial keratitis. The cornea has been infected by microorganisms following a trivial trauma, and the patient presents with bacterial keratitis. Centralmost part picture is of a sty, acute staphylococcal infection of the hair follicle root. Besides it, you can see is proptosis. It is a case of thyroid eye disorder where we call it exophthalmos. Proptosis means forward protrusion of the eyeball, but whenever the etiology is thyroid problems, we call it exophthalmos. Lower three pictures are pictures of the retina, fundus examination. On the left side, you can see the upper half of the retina has been detached. The retina is in the form of a grey-white curtain with numerous folds. So it is a case of rhegmatogenous retinal detachment. The centralmost part, lower line, is a patient having diabetic retinopathy, where you can see macular edema and numerous hard exudates over the posterior pole. And the last picture is a case of central retinal venous occlusion. The central retinal vein is the main vein which drains blood outside the eye, and whenever it gets occluded, because of back pressure, the capillaries rupture all over the retina and you see numerous hemorrhages over the retina. The patient usually presents with sudden painless visual loss. But the visual loss is so sudden and almost the patient is blind that the patient contacts the eye hospital within a short time. So what is important to you is history taking. You will be given a case in your exams. Please be quiet, keep silence. And whenever patient is presented to you, these are the points under which you have to take the history: the ocular history, past history, family history, and personal history. Usually in ophthalmology, you have main 4 or 5 complaints. It can be dimness of vision, redness from the eye, pain in the eye, and watering from the eye. Whenever the patient complains of dimness of the vision, we have to specifically ask whether it is for the right eye or the left eye or both eyes, whether the dimness of vision is sudden or gradual, whether it is stationary or progressive, whether it is painless loss of vision or painful loss of vision, whether it is for distance or near or both, and any other associated complaints like diplopia, that is double vision. So usually from the history part, depending upon the patient's complaint, you get some clue about the diagnosis. Second is redness of the eye. Third is pain in the eye. What is the character of the pain? Whether it is dull aching pain, severe throbbing, unbearable pain, in which part of the day that pain is more, and watering from the eye, whether it is clear fluid which is coming out from the eye, whether it is associated with mucoid discharge, mucopurulent discharge. Does the patient complain of stickiness of the eyelids in the morning when the patient wakes up? Whether the watering is constant or intermittent, and whether it is associated with redness or not. So these are the main 4 cardinal symptoms with which a patient can present in the OPD. For the past history, you will ask about any similar complaints in the past. History of other eye disorders. Apart from what you are seeing on examining the patient, did the patient have any ocular diseases in the past for which he or she has consulted an ophthalmologist? What treatment was taken at that time? Is there any history of eye surgery done? Usually most commonest surgery is cataract surgery. So whether the patient has undergone cataract surgery either in right eye or left eye with intraocular lens, was the post-operative recovery period smooth? The vision was good in the post-operative period. Is the patient wearing glasses after surgery or before surgery? Patient can be high myopic. He is wearing -8 diopter glasses since childhood. Or a phakic patient can be wearing +10, +12 diopter glasses. So inquire about the glasses. And any systemic illnesses which the patient is suffering, major illnesses like diabetes, hypertension, any systemic infections like tuberculosis. So depending upon the findings, ocular findings, you will ask in more detail. Suppose you are examining the fundus and you see that there is chorioretinitis and you think it can be tuberculosis in origin. You can ask about whether the patient has suffered from tuberculosis in the past or not. Family history is important because there are certain disorders which can be transmitted from one generation to the next. All ocular congenital anomalies since birth, like congenital cataract, squint, ptosis, iris coloboma, chorioretinal coloboma, absence of the eyeball, that is anophthalmos, absence of the lens, that is aphakia, congenital aphakia, small cystic eyeball, malformed eyeball, or microophthalmos where the eyeball is very small in size. So all these congenital anomalies can be genetic. Primary open angle glaucoma, yes, sure, there can be a family history which is positive. Similarly for squint, retinitis pigmentosa, where the main complaint would be dimness of vision at night time, and myopia. High myopia can also be hereditary. On torchlight examination, preliminary inspection of head, face and eyes from a short distance. You are expected to do only torchlight examination in your exam. Okay? So carry a torch with you. Distant direct examination, that is the position of the head, whether there is a head tilt or head turn. This is seen particularly whenever the patient is having paralysis of extraocular muscles, whether there is any facial asymmetry, signs of facial paralysis. You know the signs of facial paralysis, right? Because that can affect the eye in the form of inability to close the eye properly because of paralysis of orbicularis oculi muscle. So the patient can present with exposure keratopathy. Whether there is any hair loss of the eyebrows, which may be suggestive of leprosy, depigmentation, or frontalis overaction in cases of ptosis. Whether the palpebral fissure is very wide or very narrow. Whether there is any drooping of the eyelid. Then the size of the eyeball overall, whether it is a small sized eyeball, a large sized eyeball, position of the eyeball, whether it is protruded forwards, whether it is sunken, deviated, that is squint. So all these features can be visualized on distant examination with the help of a torchlight from a short distance. Next comes the examination of the eye properly, that is torchlight examination. First always examine the right eye and then go for the left eye, irrespective of the complaint of the patient. Suppose the patient complains that I am having problem only in my left eye, even then make it a routine always to examine the right eye first and then the left eye, so we will not miss out anything. And these are the points under which you will note down your findings. Starting from the eyelids, then the lacrimal apparatus. The lacrimal apparatus cannot be examined, you cannot visualize the lacrimal gland or the lacrimal drainage system, the lacrimal sac, nasolacrimal duct, but there is a regurgitation test known as the Roplast test when you apply pressure near the medial canthus over the lacrimal sac. If it is if there is a nasolacrimal duct blockage and if there is stagnation of the contents, then they will regurgitate out via the canaliculi into the palpebral fissure. Then examination of the conjunctiva, sclera, cornea, anterior chamber, that is the space between the cornea and the iris. Examination of the iris, the pupillary reaction to light, very important. And behind the iris you have the crystalline lens, which needs a dilated pupil for thorough examination. So on torchlight examination, you can view only the anterior segment of the eye till the crystalline lens. For the examination of posterior segment of the eye, the vitreous humor, retina, choroid, optic disc, the retinal blood vessels and the retinal periphery, you need to dilate the pupil and use an ophthalmoscope. You are not expected to do posterior segment examination in your patient. So that is done by an ophthalmoscope, an indirect ophthalmoscope in the retina department. Now if we look into more detail, lids, what points you will note down? The position of the lid margin in relation to the cornea. The corneal diameter is 12 millimeters. Normally the upper 2 millimeters of the cornea is covered by the upper lid when the person is looking straight forward. And the lower lid touches just the inferior limbus. So if there is excessive drooping of the lid, it will cover more part of the cornea. Or there is lid retraction, the upper limbus or the upper sclera would be visible. So you note the position of the lid margin, any thickening of the lid margin, any redness of the lids, edema of the lids, swelling of the lids, misdirected eyelashes which is known as trichiasis, scanty eyelashes which is known as madarosis, white colored eyelashes which is known as vitiligo, and matting of the eyelashes whenever the patient has conjunctival discharge and all the eyelashes are matted together. Lid margin examination is also important. Inward turning of the lid margin is known as entropion. Outward turning is known as ectropion. Any inflammation of the lid margin is known as blepharitis. Lacrimal system. The lacrimal sac is situated near the medial canthus in the lacrimal fossa, and any redness or swelling near this sac area is suggestive that the patient might be suffering from chronic dacryocystitis. Long-standing chronic dacryocystitis can result into a fistula formation over the sac area, and regurgitation test, that is Ruppler's test, can be done to examine the patency of the nasolacrimal duct. Conjunctiva, you have the bulbar conjunctiva and the tarsal conjunctiva. Any redness, any swelling, edema of the conjunctiva which is known as chemosis. Subconjunctival hemorrhage, there is accumulation of blood between the conjunctiva and the sclera, and any pigmentation of the conjunctiva. Tarsal conjunctiva, you look for, invert the upper lid and you look for the follicles, the papillae, any scar tissues which is suggestive of trachoma. Presence of a membrane in case of membranous conjunctivitis. Presence of any foreign bodies. Sometimes a patient comes to you that something has fallen in my eye. There is a foreign body sensation. You cannot visualize any foreign body over the cornea and the conjunctiva. You just invert the upper lid and sometimes you find the foreign body on the back surface of the lid. For the cornea, normally it is a clear transparent structure. You note down the diameter of the cornea, the curvature, whether it is normal or excessively flat or excessively conical in shape, any opacities over the cornea, any vascularization. Normally the cornea does not have any blood vessels, but are there any blood vessels present? It is suggestive of an old corneal pathology. Presence of corneal ulcers. Patient can have a bacterial keratitis, a fungal keratitis or a viral keratitis. And presence of corneal edema may hamper the transparency of the cornea and reduce the visual acuity. Please keep silence. If no, you are not interested, you can walk out, please. It is for you that we are here, okay? So there is no point in talking. If you are not interested, please go out. Looking to the sclera, normally the sclera is white in color. Look for any pigmentation or uveal tissue, melanomas may be sometimes seen protruding through the sclera. Presence of scleral nodules and redness which may be suggestive of scleritis or episcleritis. Anterior chamber situated between the cornea and iris normally contains aqueous humor. Look for the depth of anterior chamber, whether it is normal, excessively shallow or very deep anterior chamber. There are different causes for shallow and deep anterior chambers. And Sometimes it may contain pus, where you call it hypopyon, or there can be presence of blood in the anterior chamber, where we call it hyphema. Or sometimes after cataract surgery, you can see some residual lens matter present in the anterior chamber. Pupillary size and shape is very important. Position of the pupil and reaction to light, direct as well as consensual light reflex, has to be noted. That is also a very important finding. Normally when we throw light on the patient's pupil, the pupil will constrict. So that is normal reaction to light. Examine the iris pattern, the color of the iris, and presence of any eye movement, iris movements with the movement of the eyeball. Iridodialysis is a tear in the root of the iris, which may be following some blunt trauma or after surgery. And synechias is adhesion of the iris. When the iris gets adherent to the anterior cornea, we call it anterior synechias. And when the pupillary border gets adherent to whatever is there posteriorly, behind the iris, it may be the natural lens, it can be an intraocular lens, then we call it posterior synechias. Lens examination, as I told you, has to be done with a dilated pupil. Look to the color of the lens. Normal lens is totally transparent. Any opacities in the lens is known as cataract. And we also note the position of the lens. Following some trauma, few of the zonules of the lens might have been broken and the lens is slightly shifted from its position. We call it subluxation of the lens. And if all the zonules are broken, the lens falls into the vitreous cavity or may sometimes come into the anterior chamber, where we call it dislocation of the lens. After examining, you measure the visual acuity, right eye and left eye on a Snellen's distant visual acuity chart. Measure the intraocular pressure with a non-contact tonometers. Do sac syringing, blood pressure and random blood sugar. And after dilating the pupil, we again do a slit lamp examination to examine the lens and a fundus examination to evaluate the posterior segment of the eye. So these are few pictures of common eye diseases. A chalazion of the upper lid, which is a non-infective granulomatous inflammation of the meibomian gland duct. It is a painless swelling which the patient presents with, gradually increasing in size, and such a large swelling usually requires surgical excision. You can have an acute inflammation of the lid margin, redness, severe pain and a swelling because of acute staphylococcal infection of the hair follicle root. This is a stye. This is a case of pterygium, which is a triangular wing-shaped structure situated over the cornea, encroaching from the bulbar conjunctiva, most commonly on the nasal side. More seen in persons who are exposed to dry, sunny climates, who are working open in the sun. Patient's pupil has been dilated, and you can see there is a opacification of the lens, with some part of the lens still being transparent and some part opaque. So it is a case of immature cataract, which can progress to a mature cataract if the patient does not get operated. So a pearly white opacity of the lens. All the lens fibers have become opaque. So this is a case of mature cataract. Still the patient doesn't get it operated. The cortical fibers of the lens get converted into a milky fluid, and the nucleus, the orange color structure which you see, sinks down into the capsula bag because it is no longer now supported by the cortex. And this is a case of hypermature Morgagnian cataract. Complete absence of the lens is known as aphakia. Just the lens has been removed, IOL has not been implanted, we call it aphakia. If you implant the intraocular lens, we call it pseudophakia. You have a shiny reflex in the pupillary area, by which you come to know that this eye is pseudophakic. You can have an infection of the cornea fungal keratitis with hypopoien. You can see there is pus in the anterior chamber. So this is common in agricultural workers who have injuries with a thorn or a branch of a tree. And we have to give specific antifungal drugs to treat. Even after this lesion gets healed, it will result into a permanent corneal opacity. And if that opacity lies in the central part of the pupil, it can affect the vision lifelong. Similarly, you can have bacterial keratitis, typical dendritic ulcer of viral keratitis. Herpes simplex and herpes zoster are the two common viruses which can affect the cornea. It may be associated with skin lesions also. Case of acute dacryocystitis. You can see there is a painful swelling near the medial canthus. You need to give heavy antibiotics and analgesic anti-inflammatory drugs, and after this acute inflammation resolves, the patient has to be treated for the dacryocystitis part. There is a blockage in the nasolacrimal duct, and we do a DCR surgery, that is dacryocystorhinostomy, where an anastomosis is made between the lacrimal sac and the nasal mucosa to bypass the nasolacrimal duct obstruction. Okay. So this was all about eye examination. Next lecture would be on ophthalmic drugs.
તમે અટેચ ચેન્જ કરી દો, અનાઉન્સ કરી દઉં છું અહીંથી.
હલો, આપણે 2 કલાક શાંતિથી લેક્ચર સાંભળી ના શકીએ? કોલેજમાં તો નથી સાંભળતા, અહીંયા તો સાંભળો એટલીસ્ટ, હે, એક્ઝામ પહેલાં. The next lecture is for the instruments. I'd like to invite Dr. Kamini Prajapati Madam. She is Associate Professor at BJ Medical College.
So, good afternoon everyone, and if you are knowing everything, why are you here? Why you have registered? Huh? You are future doctor, you are future of us also. Yes or no? Will you treat us in future? Yes. Then behave like a doctor, right? And wish your theory papers were good, and now you have a practical exams. And we have already said the PPT last year, so you should ask your senior. And this year, our sir has already managed YouTube live of these sessions. So just listen and see the PPT. Don't waste your time by taking pics, right? Thank you. Anyone wants to ask anything? Okay. Instrument in ophthalmology. As Dr. Parul Madam has already talked, how does the eyeball look? We have 2 lids in each eyeball. So for thorough examinations, we need speculum. I don't go in very much detail as it will take whole day, and I have allotted only 45 minutes. So these are the different types of speculum, which are few of the instruments are here also on the table. You can see after this session is over, all 3 sessions are over. This is the wire speculum. You can identify it by a thin spring-like action of the speculum with 2 curves. Second is the universal eye speculum, in which you can adjust the speculum as per the eyeball size by the screwing mechanism. The third is backward eye speculum with these blades, stout blades. So you can easily differentiate between these three. And as you know, it is useful for any surgery, whether it is intraocular, extraocular, whether you have to remove the foreign body in the OPD, or you have to do the pterygium surgery, or you have to do just the examination of the patient. It may be child or maybe the adult. Then the gastrovisual caliper. This is the eye instruments, they are very tiny as compared to your general surgery or orthopedic instruments. In this, the millimeter, this is given in the millimeter, and you have to adjust these two blades and see what is the diameter of the cornea, conjunctiva, how much muscle recession or resection has to be done in cases of strabismus surgery or ptosis surgery, how much LPS or levator palpebral superior resection to be done. It is also useful in anti-glaucoma surgery. Why? Because you have to measure and cut or dissect the scleral flap, outer scleral flap, as well as how to make the inner window. Whenever you are going to do the small incision cataract surgery, usually we have to go 3 to 4 mm posterior to the limbus. So you have to measure with this caliper. Or any graft. Graft is used in the either in the pterygium surgery or with the leaking blab or with the use of the corneal surgery. Then in surgery you are seeing large artery forceps. This is smaller one, so it is called the mosquito artery forceps. As all the forceps, it has 3 compartments. You know which are 3? Catch, clamp and crush. Very good. So to hold the any blood vessels, any tissue, any non-viable material like the gauze species, or you have to just scrub the eye or paint the eye with the use of betadine or spirit soap. Then this is the small seizure, it is called the tenotomy seizure. How do you differentiate between forceps and seizure? Those 3 grooves are not here in the seizure. So to separate the delicate tissue without damaging the surrounding area in cases of any surgery, but it is usually used in cases of enucleation to cut the superior rectus suture in cataract surgery. So whenever the tissue or material is thick, then you can use the tenotomy seizure. As the name suggests, it is for the cutting of the tenons, right? Then this is a needle holder. There are different types of needle holder, but the common instrument what usually asked in UG exams, that those are here. So this is the needle holder to hold the heavy gauge needles thicker than 60, which is usually needed in lid surgery, bridal suture of the superior rectus, skin and muscle suturing. Then you have to differentiate between this baraquer's needle holder. This is delicate as compared to this needle holder, and to hold the fine gauge needles we are using, that is 50, right, 80, 90 suture material, 10, and 11 suture material. So it is usually for taking the suture of the cornea, sclera, conjunctiva, right, or any extraocular muscle suturing in squint surgery. Then is different types of forceps. This is Lim's corneoscleral forceps. The name itself suggests is the holding the cornea and the sclera, which is usually in any ophthalmic surgery. Then you have to differentiate between these Pierce-Hoskins forceps. In these Hoskins forceps, you have a fine tooth. It is here, so you can see after the session, right? Because if I can show you just now, the last benchers cannot see. So it is usually used for firm holding of the tissues. And while holding the tissue, you should be very aware that it should not torn the tissue. So whenever you have to cut something or you have to take the suturing, it is for the holding purpose. This is Devakar's seizures. It is very unique. It is used to perform iridectomy. Part of the iris want to cut, that is called iridectomy. It is usually done in which surgery? Anti-glaucoma surgery, or in sometimes cataract surgery also, right? And to cut the prolapse form vitreous and pupillary membrane. So whenever patient has a trauma or patient has a subluxed or dislocated lens with the vitreous in the anterior chamber, you can cut with the scissors. Ideal is anterior vitrectomy. Then the superior rectus holding forceps. So this is very stout as compared to other tying forceps to hold the superior rectus muscle. So while we have to pass the bridal suture to the superior rectus, so if you can pass the suture and hold it with the artery, the eyeball turns down. So it should be useful in which cases? Cataract, small incision cataract surgery. You should not need in phacoemulsifications, right? Then anti-glaucoma surgery. In anti-glaucoma surgery, the other option nowadays is you can pass the traction suture from the cornea, right? So also you can turn the eyeball downwards. So this is capsular axis forceps. Atrata capsular axis forceps. What is capsular axis? Before doing any type of cataract surgery, you have to perform the raxis to go inside the lens. So there are various types of raxis, you know. In ECC you can do can-opener capsulotomy, but when in the phaco particularly, if you want to do the capsular axis, continuous curvilinear capsular axis, and there are many types of the capsulotomy, and the instrument you can do with the 26 gauge needle. Then you can do with this forceps. If you have not completed the axis with the 26 gauge needle, you can use this forceps. These forceps, like a tooth forceps, there is a small tiny tooth at the end. So you can hold the anterior capsule and tear it. Then tying forceps. So you should differentiate between this tying forceps, one tooth forceps, rexis forceps. The tying forceps, this is the titanium. So material may be stainless steel or titanium. Titanium, the half-life is long, but they are very costly. So tying forceps, they are toothless. Then appellation forceps. As madam was talking about the tracheosis, right? In entropion cases, you can have an inward of the eyelaces. So if you want to remove it, then there is a stout soft blade forceps. It is called the appellation forceps. So you can ask about the trachoma, right? Now the trachoma is eliminated. You must have heard that. This is Macpherson forceps. A Macpherson like a tying forceps, but it has a curve like this. But if you want to differentiate between Raxis forceps and this Macpherson forceps, there is no tooth here. Toothless, curved Macpherson forceps. To hold the superior haptic of the or optic of the IOL. The IOL has two parts, optic and haptic. So you can hold the optic with this forceps. So it cannot have any scratch on the IOL. Then to tear up the anterior capsular flap, that you have not completed the capsulotomy, and can be used for tying the suture. You have taken the suture with needle holder, now you want to tie it. So with the help of tying forceps and a simple tying forceps with the one hand, that the left hand, and with the master hand, you hold with the Macpherson forceps and give a knot. So you usually 10-0 corneoscleral suturing, you want 3-2-1 knots. First 3, then 2, and then 1. For conjunctival suturing, first 2 and then 1. Then the suture will not slip. So now the third instrument, that is wet-fed bipolar electrocautery probe. In the ancient time when I was resident, we were using hot point. We have to ask the sister to lighten the spirit lamp, then the hot ball point cautery was there, and we have to cauterize the vessels. As during phacoemulsification, if you are doing the corneal incision, there is no need to cauterize anything. As madam has already told that the cornea is a avascular structure. But if you want to do the MSICS, manual small incision cataract surgery, trabeculectomy surgery. Then after cutting the conjunctiva and tenons, there is episcleral vessels. So you have to cauterize it. Why we have shifted from the hot ballpoint cautery to the bipolar electrocautery? Because there are certain advantages. There are no such scarring as it was happened with the cautery, right? Then handle. They are very tiny, Bard Parker handle. So you have to attach this disposable blade. If it is like this bhala type, it is 11 number blade. So it is used for, and you have to cut anything stably. This is like a stab knife. And this is a 15 number blade. Can you see this difference? Can you see my arrow, browser arrow? Yes. So in this you have a like this tab, and this you have a curved like this. So it is for marking the corneoscleral incision for cataract extraction, making the scleral flap in antiglaucoma surgery, or you have to just scrap the corneal infiltrate on the cornea, right? And send for the histopathological examination. Nowadays, for SICS and phacoemulsification, we have shifted these newer knives. They are available either in the disposable form with the plastic material, and they are also available with the diamond knife. But diamond knife, they are very costly. So this first is the crescent. Can you see this? See this? On the edges of this two sides, it is sharp, right? So to make the sclerocorneal tunnel, first you have made the incision with the 15 number blade, then you have to enter with the crescent knife into the sclera. That should be partial thickness. So scleral dissection like this. Two sides are sharp. So you can do the scleral dissection, go 1 millimeter into the cornea with this. And if you are doing the trabeculectomy surgery or antiglaucoma surgery also, you have measure 4.5 mm triangular or rectangular flap. Then also you have to dissect it. Achha. Just a small announcement. The car number GJ27EG5533, GJ05RB2381. They are parked wrongly. Please go out and park it smoothly. So for SICS and trap and other thing, while doing pterygium surgery. Suppose pterygium is already encroached on the cornea, you have to dissect from the corneal part, right? So for that you need the crescent knife. Then the keratome. So you have to differentiate between the crescent knife and keratome. So in the keratome, can you see this sharp tip? Like this, sharp tip. And this crescent, there is no sharp tip, right? So this is the difference between these two. So when we want to enter into the anterior chamber, after doing this tunnel, you just deepen or have a dimple with the keratome and enter into the anterior chamber. Any surgery, cataract surgery, antiglaucoma surgery, you can use it. Then wound enlarger. So it is also should be differentiate between keratome and wound enlarger. Can you see this shape? Suppose I have done phacoemulsification, but I need to enlarge my incision. Then I have to use this wound enlarger. So it may need no suture or minimum suture, as phacoemulsification is a sutureless surgery. Last row, please, if you don't want to listen, don't disturb others. Then my MVR blade, the short form. The full form, microvitreoretinal blade and side port. The side port like this, like the 11 number blade, it is a mini version of that, right? And this is the MVR. It is a very small, the sharp edge at the tip and sides. So it is useful if you want to do the side port incision. This is the main incision with the crescent knife and keratome, and in the side port it is very tiny for when you need the side port for the paracentesis. Or suppose you want to do capsular axis with the closed eyeball. You have to inject viscoelastic, you will complete the capsular axis and then go into the anterior chamber and then finish your cataract surgery, right? And in the case of glaucoma surgery, you may want to inject pilocarpine if it is a dilated pupil, or if you want to inject air, you can inject from the side port. After thorough irrigation aspiration of the lens matter, sometimes what happened? The subincisional lens matter, that is the superior, you usually do SICS superiorly, right? And phaco temporally. So subincisional lens matter you cannot do from the same side, superior side. So you have to go from the paracentesis side with the Simcoe cannula or irrigation aspiration cannula and wash it. In phacoemulsification, there are two types. Somebody use unilateral IA or some can do bimanual IA. So in bimanual IA, you need two side ports or two side ports with this blade or with the MVR blade. This is the cystitome, what I was talking for the capsulotomy or capsulorhexis. 26 number needle, economical, and you have to just band it with your needle holder. This is the capsulotomy scissors. So we have seen 26 gold needle, first, second capsular axis forceps, third is the capsulotomy scissor. So suppose in cases of mature or hypermature cataract, you will not able to do the complete axis, you can cut it with the capsulotomy scissor. Then the corneoscleral scissor. This is the main instrument to cut the cornea or sclera in all the surgeries. But in phacoemulsification and SICS, you just want these incision if you want to do the peritomy. This is the venous scissor, small version of the corneoscleral scissor. Can you see? In exams, sometimes you are confused with the small needle corneoscleral scissor and venous scissor. So needle holder spring-like action as it is with the corneoscleral scissor, but corneoscleral scissor can cut, the needle holder cannot. While the venous scissor, it is a small version of the corneoscleral scissor. It may be straight or it may be curved. So you can do iridectomy, any small vitrectomy, cut the suture after tying it, cutting the pupillary membrane or lamellar corneal tissue, you can use this venous scissor. Then this is iris spatula. Straight like this, two side, there is a flat surface. So just if there is iris prolapse, you can reposit it with the iris spatula, and sometimes if you want to manipulate something from the paracentesis side, you can use this spatula as it is blunt and it cannot hurt the inner structures. This is the vectis. Can you see this round? So it is a wire vectis. It may be available with the irrigating vectis. In irrigating vectis, you can see the small holes in this round. So it is usually useful to deliver the nucleus. Then it is a irrigation aspiration cannula used in extracapsular cataract surgery like SICS. This is just manual aspiration of the lens cortex. Suppose there is a hyphema, then also you can aspirate it. Anything in the anterior chamber you can aspirate with the IA cannula. And third cause is in the surgery you can use to remove the viscoelastic substances. Then this is the lens expressor. So you might confuse with the iris repositor and lens expressor. The iris repositor usually have two ends flat, and while lens expressor rounded and with one tip. So if you want to deliver the nucleus, whenever you have a open wound, you can help a nucleus to be out with the use of lens expressor and iris repositor. Then you might confuse with the IOL dialer and chopper. So dialer is used to dial the intraocular lens, what we are inserting into the eye. So when you use the foldable IOL, particularly with the phacoemulsification, you can use the T dialer, in which you have a small tip between the tip and shaft of the instrument. It should be held at the junction of the optic and haptic. While if you have used PMM IOL with the holes, 2 holes at the IOL, then you can use the simple dialer or Simski's hook. And even you can use to manipulate your lens fragment or lens in the anterior chamber or in the back. While the chopper may be sharp edges or may be blunt. Chopper is used for chopping the nucleus. What is the literal meaning of phaco? Phaco means lens emulsification. In chopper, there are different methods of phacoemulsification, and one of it is stop and chop. So if you want to chop, just hold the nucleus with the vacuum and then chop it. The chopper should be in the nucleus and crack the nucleus. So this is useful for the chopping part. Then the callus descemet membrane punch. So you might be confused with that needle holder, superior rectus bridal suture needle holder, and this punch. But punch has a spring action with a good grip. Can you see this ridges over the shaft? And it is have a like this, like a Callisian scoop. There is a one sharp end here. So So now this is the antiglaucoma surgery pic. This is a scleral flap. I made the inner window. For this you have to enter with this punch like this and cut it. It has a spring action. Cut it 1 to 1.5 millimeter of the sclera, that is the inner window, and then do the iridectomy with the scissor or venous scissor. This is the muscle hook. So you can confuse with the lens expressor. The muscle hook can be used with the in place of lens expressor, but muscle hook main use is for handling the extraocular muscle during squint surgeries, enucleation and retinal detachment surgery. This is the lead plate. So while doing the lead surgery, you just guard it with the plate. So suppose inadvertently you can cut deeply, it doesn't hurt the eyeball, it doesn't injure the eyeball. So it can be used in any lead surgery. This is the entropion clamp. So if you open it, it has, this is the open part and this is the closed part. So open part is towards the skin and this closed part towards the eyeball to prevent the injury. This is a ptosis clamp. In cases of ptosis surgery, like this, we have to hold the muscle with the clamp. Then lacrimal or punctum dilator. So whenever you see there is punctum occlusor in the child particularly, there is nasolacrimal duct obstruction, and if there is a punctum is small or stenosis, you can dilate with this punctum dilator. It has a small tip here. Then the lacrimal probe. So after dilating the punctum, you can insert this probe. They are available with the different sizes 0, 1, 0, 2, 0, 3, 0 like that. So in the child, sometimes only the probing, which is called the probing, will be enough to open the passage. Then this is a 27 gauge cannula used for lacrimal sac syringing and for hydrodissection and hydrodelineation in cataract surgery, and it is usually attached with the syringe for injecting the viscoelastic substance also and air injection. This is the, you can see like a trishul. So it is a lacrimal wound retractor to retract the tissues during lacrimal and lead surgeries. It's called cat's paw. Cat's paw. Then Desmar's lead retractor, everting or double everting the upper eyelid. The most common site of foreign body is which area? Yes, so you have to double evert it. then you can find out the foreign body if in case you have missed it. So any lead surgery, you can have a proper exposure with the lead detector. If you are doing evisceration, then this is the evisceration curate to evacuate every part of the uveal tissue. And enucleation. So there is a difference between enucleation and evisceration. You must know the indications and procedure, right? So this is a Caesar for the enucleation, and this is it is called the optic nerve head guard. So suppose this is the eyeball and this is the optic nerve head. So I have to insert this optic nerve head guard like this to prevent the further injury of the optic nerve head while cutting it from the body. Okay. So they might ask when you need the large optic nerve head stump. In cases of malignancy, particularly retinal blastoma. So this is a figure of this. You can just hold like this, pull the eyeball upwards and then cut it. So inadvertently you do not perforate the sclera. Once you perforate the sclera, you cannot use the eyeball for the clinical purposes, right? And if you have done the enucleation for like uveal melanoma or any malignancy and patient wants implant, then you can implant. There are different types of implant available, but it is not for you. Then calazion. So calazion clamp, it should also done either with the skin side or with the conjunctival side. So its main purpose is to clamp. Clamp purpose is just you should avoid the bleeding. And what is the incision for the calazion? Vertical or horizontal on the conjunctival side? Vertical. Why? Only one, huh? So there are meibomian glands situated vertically. So if you cut horizontally, it will cut many glands, right? Then this is caries and sponge used in decryocystorynotomy surgery, in which you need the lacrimal sac dissector. It is a one end there is a scoop part and other end is a oblong part. So you can be asked about the decryocystitis. And this is the periosteal elevator. You can do anything from any side. Then this is chisel and hammer for DCR surgery or orbitotomy surgery when you have to break the bone. This is a corneal trephine in cases of keratoplasty. Then there are different types of suture like 6-0 Vicry suture. It is used in squint surgery, vitreoretinal surgery, oculoplasty surgery. We can take the traction suture, and nowadays I can do the get that is in children we have to pass this suture in the Slim's canal. 8-0 Vicryl. They are all absorbable or non-absorbable? Bolo, this is not example, absorbable. Then 4-0 silk, you have to part the suture for superior rectus or in the lid or the skin part. 6-0 for the skin suturing, or you can use in cases of closing the ports in the vitrectomy surgery. 10-0 nylon, which are main is used in our part, that is you have to close the tunnel in cases of leaking. You have to use for flap suturing in cases of trabeculectomy, or 10-0 and 11-0 used in keratoplasty. And there are different types of tonometer which works on different principles, like Seor's tonometer, indentation. Now we are not using this tonometer, but I have the Seor's and Perkins both. Perkins based on the principle of the applanation tonometry. There are different types of gonio lens. You should know 2 mirror, 3 mirror and 4 mirror gonio lens. And they are indirect gonio lens and direct gonio lenses as well. The indirect gonio lenses, we have to see whether the anterior chamber angle is open, closed, narrow, any foreign body malignancy in every patient. While the direct gonio lens, Swan-Jacob lens, this is Swan-Jacob lens. It is usually used for surgical purpose, particularly in the pediatric patient. And nowadays, we can do minimally invasive glaucoma surgery in the adult as well with the use of direct surgical gonio lens. So, if you have asked about the 3-mirror gonio lens, they may ask which part of the lens is used for seeing which structure. So, the central part is to see the posterior pole, macula. Then this is for the equator, then ora serrata, and triangular part is used for seeing the anterior chamber or iridocorneal angle. So, for as madam says that if the fundus examination, we usually don't ask you or don't expect to see the fundus examination by you, but the instrument may be kept in a table, that is direct and indirect ophthalmoscope. You must know everything about the direct ophthalmoscope, and they can ask about direct versus indirect ophthalmoscope. What is the advantage of direct and what are the advantage and disadvantage of indirect ophthalmoscopy? I think your theory was over, so you must be knowing all this. Then other lenses, there are 78 and 90 diopter and 20 diopter lens. Plus 20 diopter lens is used in indirect ophthalmoscopy. 78 and 90 diopter lens is used while doing the stereoscopic examination of the optic nerve head and macula while patient is seeing on the slit lamp. Right? Then intraocular lens used in after cataract surgery. The parts of it, haptic and optic. 2 haptic, 1 haptic. They might be foldable, non-foldable, hydrophobic, hydrophilic, monofocal, multifocal, spheric, aspheric. You must know everything, right? Then those are posterior chamber IOL. Now the anterior chamber IOL. Anterior chamber IOL may be kept in the iris fixated IOL, or it may be the Kalman's IOL, or there may be a posterior iris claw IOL. It should be clamped in the posterior part of the iris, so you cannot see it from the anterior chamber. Suppose a patient has an aniridia or traumatic iris defect, you can use these prosthetic devices which is a like brown black serrations. So why we are using this type of devices in cases of aniridia and iris defect? What is the main complaining of the patient in case of aniridia? All right. We have a central pupil, right? The patient is aniridia, there is a absence of iris. There is only rudimentary root of the iris is present. So patient may have photophobia, severe photophobia. So to prevent this, you can use these devices. Then IOL injector, the foldable IOL from the 2.8 millimeter or 3.2 millimeter incision should be go with the help of either straight injector like this. Like this. The IOL is kept in this cartridge. Cartridge is kept here and you have to just inject the IOL in the posterior. In the other type of the injector, you have to just rotate it like this and it can go into the posterior chamber. Then Snellen's visual acuity chart, right? Then retinoscope. So for objective refraction, how do you dilate the different types of patients' pupil? Like the patient is children, less than 3 years old, more than 6 years old and adult. Atropine eye ointment 3 times a day, ideally for the small child. Home atropine eye drops for more than 6 years old child, and for adult, tropical seal when there is a no accommodation, right? So there are 2 types, either it is a from plain mirror or plano concave mirror, or there is strict retinoscope like this. So you have to differentiate between direct ophthalmoscope and strict retinoscope. So retinoscopy, from retinoscopy, how do you say this patient is myopic and hypermetropic? And how do you neutralize this, right? So they might give you a different types of lens like this. So how do you recognize if this is a minus lens, or concave lens or convex lens? No? So you have to just have a point of focus and move the lens, whether it is with the movement or against the movement. When it is a cylindrical lens, you might have a wavy margin if you see against the road, right? So you have to differentiate between convex, concave and cylindrical lenses. Then color vision chart, Ishihara's color vision chart, what we are mainly used for red-green color blindness. Emsler grid chart, it is used usually for macular pathology. So a normal patient can see this point of focus with straight lines. Every lines are straight. But if the patient is a macular pathology, they might see the wavy line. And you can give this chart to patient at home to see the patient's macular pathology progression also. Then trial set with the lenses. They are containing trial frame, different types of lenses, prisms, pinhole, occluder and stenopic slit. So mainly trial frame. How many slots are there in the trial frame? 4. 1, 2, 3 and 1 behind. So each lens to be placed where? So high powered lenses in the first compartment, second spherical, third cylindrical and fourth the accessory lenses. Accessory lenses, occluder, pinhole, etc. So convex lens, what I told, the movement in the opposite direction and you see the magnified image. So you remember like this, magnified image and movement in the opposite direction. Concave, minification of the image and the same direction. Cylindrical, wavy lines. Maddox rod to detect the horizontal or vertical strabismus. Cylindrical, you can see the cylindrical rods. So point of focus is converted into the lines. Then the prism. Can you see this elevated area? In this part. So it is flat here, elevated here. Only this part. So this is called prism. It is usually written on that also. Then occluder, used to occlude the one eye to see the vision in the other eye. Pinhole to differentiate between the refractive error is due to the cataract or any other macular pathology. So if the visual vision is not corrected with the pinhole, it is usually due to the macular retinal pathology. Then stenopic slit, linear slit. Anybody wants to know about that slit or already having knowledge about this slit? No? So this is about the pinhole, right? And so if it is improves, it is due to refractive error, does not improve, ocular or neurological pathology, worse than unaided visual acuity, then it is macular pathology, better it is due to the any astigmatism or opacities. So stenopic slit should be kept at one eye and then you rotate it. If the patient has uniform halos, it is not cutting, then it is usually due to the glaucoma. What happens in glaucoma? Due to the increased intraocular pressure, there is a diffuse corneal edema, right? So there is a uniformity. While in cases of intumescent cataract, those patients, the glaucoma halos will be broken. Then placidus disc, now they are not keep it. Then Jackson cross cylinder. So it is like this and it has 4 lines. It used to after giving the correction, it is used to refine the axis and power of the cylinder. Some of you might be wearing cylindrical power. So you must be knowing the axis. Suppose the axis is different than actual axis, you might have a blurred vision or you have a difficulty while walking or stepping, right? So used for astigmatic correction. Then different types of contact lens, either it is for optical purpose, therapeutical purpose, enhance the performance or for the cosmetic purpose. So it can be used in cases of keratoconus, bandaged contact lens if there is an impending perforation. Nowadays the drug delivery contact lenses are also available, particularly for the anti-glaucoma drugs and in cases of the orthokeratology cases. Then if somebody has put the phacoemulsification probe and anterior vitrectomy probe both. So you have to differentiate. The anterior vitrectomy probe is usually tiny as compared to the phacoemulsification probe. The phacoemulsification probe has a tip which can be detached. It has a sleeve. In the sleeve there are 2 holes on the side for the irrigation, and there are 2 tubings and 1 wire at the end. The wire is for power supply with the machine, 2 tubes, 1 for irrigation and 1 for aspiration. Then there might be a certain glaucoma drainage devices which are maybe valvular or non-valvular. The one of the example is Ahmedabad and non-valvular Barvet implant, and certain minimal, what I have talked about, minimally invasive glaucoma surgery. Now we are offering for the mild to moderate glaucoma patient with or without cataract surgery. Thank you very much and all the best.
Any questions?
તો ખાલી થઈ ગયો.
બહુ બધા તારે
No.
Still the lecture on the drug is remaining, and if we conclude early, the instruments are here. If anyone wants to see, they can see after the lecture is over. We will start once everyone is settled down. Those who wants to leave can leave. Those who wants to attend, please sit quietly. Myself, Dr. Gunjan Tak. I am Assistant Professor at Narendra Modi Medical College. So commonly drugs used for your vivas, most commonly drugs used are mydriatic and cycloplegic drug and anti-glaucoma drug, antibiotics and antibiotic steroid combinations. So we'll start with mydriatic and cycloplegic drug. Can anyone tell me what is the difference between mydriatic drug and a cycloplegic drug? Anyone from the last row? Or anyone, please stand up and say. Anyone knows? Please raise your hands. If you are knowing, that's good. If you are not knowing, please stay silent for next 15-20 minutes. The mydriatic drug, they act on the dilator pupillae muscle. Either they paralyze the sphincter pupillae muscle or they act on dilator pupillary muscle. So they will just dilate the pupil, while cycloplegic drug act on the ciliary muscle. So these drugs relieves the ciliary spasm. Cycloplegic drugs are usually used when there is a strong cycloplegia and we want to relieve the spasm, especially for the pain relieving and for pediatric patients. The commonly used cycloplegic drug is atropine, which is used as 1% either ointment or in a form of drops. The dose is 3 times a day for 2 days or twice a day for 3 days. The size is approximately of a rice grain size, and it is most commonly used for the refractive error checkup in the children. The side effects of atropine is, if you are giving to the pediatric patient, you have to instruct the mother that child may have mild form of fever or rash, and if the same appears, the drug has to be discontinued. Usually there is no ocular significant side effect of atropine apart from the cycloplegia, which lasts for up to 21 days, so patient will be having photophobia, and the systemic side effects are of atropa poisoning, that is fever, rash, dry mouth, dry skin and tachycardia. The uses of atropine is for retinoscopy in the children less than 3 years of age, in patients with malignant glaucoma, in patients with corneal ulcer or uveitis. In corneal ulcer, to relieve the ciliary spasm, which is the root cause of pain in these patients. In uveitis patient, the advantage of atropine is, first, it breaks the synechia or it prevents the formation of synechia because of the inflammation. Second, it increases the inflammatory mediator available in the anterior chamber. And the third, it reduces the ciliary spasm, that thus relieves the pain in patients with the uveitis. The other drugs are hometropine, cyclopent and tropicacil, which we commonly use. The second one is cyclopentolate and hometropine. So atropine is the most strongest cycloplegic drug, followed by hometropine and cyclopentolate. Hometropine is available in 2% and 5%. The duration lasts up to 72 hours, and it is used for retinoscopy in older children like more than 3 to 5 years up to 15 years of age group. And it is also used in patients with corneal ulcer and uveitis where there is less inflammation. The cyclopent is less effective as a cycloplegic than these two drugs. The effect lasts up to 24 hours. These all drugs relaxes the ciliary muscles, and these are used as a mydriatic and cycloplegic agent for retinoscopy in older children. The other common use is following the cataract surgery, where you want pain relief as well as a cycloplegic action. And in for relief of pain in uveitic patients, corneal ulcer, more common when there is a corneal epithelial defect, we usually use a cyclopent in these type of patients. The third one is a tropicacil plus or tropicamide and phenylephrine combination. The peak effect occurs after 20 to 40 minutes, and its effect lasts for 4 to 6 hours. So the use of tropicacil is most commonly used for fundus examination in adult patients to check the diabetic or hypertensive or any other type of retinopathy, or for retinal evaluation, for doing refraction in older patients, for pre-operative dilatation before cataract surgery or before any retina surgery, and for routine fundus examination. And the dosage is 1 drop every 15 minutes, approximately 3 times, and it causes dilatation of the pupil, and there is very less cycloplegic effect. The second most common group of drugs which are asked for your viva is anti-glaucoma drugs. I think the figure is visible. So there are mainly two mechanisms of action is there. One, glaucoma occurs because of the increased intraocular pressure, so which may be either majority of time it is due to decrease in the outflow. If it is at the pupillary level, that causes angle closure glaucoma, and if it is at the trabecular meshwork level, that causes open angle glaucoma. So majority of drug either acts by decreasing the aqueous production or by increasing the aqueous outflow. The first group of drug are prostaglandin analog, which are now the first choice of drug for treatment of glaucoma. Previously it was beta blockers, but because of the dosage of prostaglandin which is bedtime, and nowadays the cost is also not much which was compared to the previous cost. So prostaglandin analogs are the first choice of drug in all type of glaucomas except uveitic or inflammatory glaucoma. There are various formulations: latanoprost, bimatoprost, travoprost and tafloprost. You may not be able to remember the concentration excuse me, which is usually written on the drops box which is given to you in your viva. The dosage of this drug is a bedtime dose, and it works by increasing the uveoscleral outflow. The IOP reduction is 30 to 35% from the baseline intraocular pressure. What is the normal range of IOP? 10 to 21. There are other two terms. One is normal tension glaucoma, where the glaucomatous damage occurs despite of normal IOP, and another one is ocular hypertension, where the IOP is high but there is no glaucomatous damage. The side effect of prostaglandin, the most common one is allergy followed by periocular pigmentation. So if you see some patients coming to OPD and having black eyes, majority of time these patients might be using anti-glaucoma medication. Hypertrichosis, that is lengthening of eyelashes. So the bimatoprost is the highest efficacy for lengthening the eyelashes. So the cosmetic industry was using the bimatoprost to elongate the eyelashes also. The most common is a conjunctival hyperemia. We have to explain the patient that after using prostaglandin, they might have redness in the eye or might be foreign body sensation, which usually wanes after 20-30 days of prostaglandin therapy. Also there is an increase in pigmentation of iris. So if some patient is using prostaglandin in one eye, that pigmentation of, you can see heterochromia between the two eyes of the iris. It increases the inflammation, so we prefer not to use prostaglandin analog in patients with acute anterior iridocyclitis, in patients with cystoid macular edema, and when patient awaits for the intraocular surgery. The second, prostaglandin is used in all types of glaucoma, open, majority primary and secondary open angle glaucomas, and traumatic glaucoma and pigmentary glaucoma. The second group of drug is parasympathomimetic drug, that is pilocarpine, which is available in 2% and 4%, but 4% is not available in India, so we usually use 2% eye drops. The main and the nowadays the only role of pilocarpine is in patients with acute attack of angle closure glaucoma. The dose is usually 4 times a day. It causes constriction of the pupil, so it removes the iris away from the trabecular meshwork, and it releases the mechanical blockage and increases the aqueous outflow. Pilocarpine, whenever the patients with acute angle closure glaucoma comes to us, the IOP is usually more than 40 millimeter of mercury. So at that level of IOP, pilocarpine usually don't work because there is an decreased blood supply to the iris. So once IOP is stable, then and then only pilocarpine can work. And pilocarpine is used in the eye having angle closure glaucoma to constrict the pupil, as well as in the other eye, so that we can do laser peripheral iridotomy. The side effect of pilocarpine, systemic if absorbed, it can cause bradycardia, increased sweating and salivation, and diarrhea. Local or systemic or topical side effects are less, but as it causes spasm of accommodation, patients majority of time may feel headache after installation of pilocarpine drops. There may be iris cyst formation and iritis and follicular conjunctivitis. What you read as a retinal detachment of side effect of pilocarpine is very rare. So please don't speak that in your viva. The contraindication of pilocarpine is inflammatory glaucoma and malignant glaucoma. The third class of drugs are adrenergic agonist or sympathomimetic drugs. These are alpha-2 adrenergic agonist. The book has given apraclonidine, which is not available in India, so we use brimonidine. There are various concentrations available, 0.2, 0.15 and 0.1. Because 0.2 have more of side effects, so they came with the lower concentration. The dosage is 2 times a day. The mechanism of action is decreases the aqueous production by stimulation of alpha receptor. Also it increases the outflow, and the major benefit of brimonidine, it also has a neuroprotective effect. So patient may have a neuroprotection which is preferable in advanced stages of glaucoma. The side effect of brimonidine is conjunctival hyperemia. It has a tendency for having severe allergic reaction, severe in the form of severe lid edema and sometimes cracking of lid crease also, and follicular conjunctivitis. If brimonidine allergy to any anti-glaucoma drug happens, we have to discontinue the anti-glaucoma drug and we have to give anti-allergic medications. Brimonidine causes CNS depression and sleep apnea, so it is absolutely contraindicated in children under 2 years of age. Beta blockers, which was the first choice of drug because it has very less side effects and it was very cost effective. Two main beta blockers used are timolol and betaxolol. Betaxolol is beta-1 selective beta blockers. The mechanism of action, it acts on beta receptors and it decreases the aqueous production. The dosage is 2 times a day. Topical side effects of beta blockers is a rare thing. Some patients may present with the superficial punctate keratitis or corneal anesthesia. But these drugs are, if they get absorbed, they can have systemic side effects, like they can cause bradycardia, arrhythmia. They can aggravate the bronchospasm in asthma patients and heart failures. So these drugs are contraindicated in patients with COPD, asthma, heart block and congestive heart failure. The next group is carbonic anhydrase inhibitors. It is available both in topical as well as systemic forms. The topical one used are dorzolamide and brinzolamide. Dorzolamide is 2% and brinzolamide is 1%. If we are using dorzolamide as a monotherapy, the dose is 3 times a day, but in combination it is used as a twice a daily, and brinzolamide is also twice a day. These are the carbonic anhydrase inhibitors, so definitely they will be acting on carbonic anhydrase enzyme and thus by decreases the aqueous production. These drugs are used in all types of glaucoma. As such, no contraindication for the carbonic anhydrase inhibitors except in patients with compromised corneal endothelium, like in patients with pseudophakic bullous keratopathy or in Fuchs dystrophy. Side effects are burning sensation and allergy. Burning is more common with the dorzolamide than brinzolamide. The second is a systemic carbonic anhydrase inhibitor, which is acetazolamide. In adult, we usually give as a 250 milligram tablets 4 times a day, or if it is an extended release, it can be also given a twice a day dose. The dose usually is 25 to 30 mg per kg per day. Mechanism is same. It is used, systemic drug is used as an add-on to the topical anti-glaucoma medication, where when patient is on majority of anti-glaucoma medication, still IOP is not controlled. So we are planning these patients for anti-glaucoma surgery, but till that time we can give systemic acetazolamide to control the intraocular pressure. The side effects of acetazolamide is there are too much side effects. It causes paresthesia and numbness of fingers because of the electrolyte imbalances. Most common is gastrointestinal symptoms, irritability and nausea, vomiting and gastritis. In patients with sulfonamide allergy, it has to be cautiously used, and because of the disturbed electrolyte, it can cause hypokalemia. So usually we ask patients to either eat banana or coconut water for the potassium supplement, and if the patient is diabetic, we can ask them to use a syrup potlor to replenish the potassium and to avoid the hypokalemia. The next group of drug is a Rho kinase inhibitors. These are ripasudil and netarsudil. The mechanism of action, it acts on the Rho kinase enzymes which are present in the trabecular meshwork, which causes remodeling of meshworks, and it increases the trabecular meshwork outflow. So this is the only drug which acts on the meshwork. Rest other either decreases the aqueous production or increases the uveoscleral outflow. This is the only drug which increases the conventional trabecular meshwork outflow. It is used as of now as an add-on in all types of glaucoma. The side effect, the most common one is a conjunctival hyperemia or red eye, followed by allergy and reticular corneal toxicity. So these are the basic topical drugs. Usually we starts with the prostaglandin analog. If IOP is controlled, it is well and good. If not controlled, we can add on the different other drugs. Most common used combinations are prostaglandin with beta blockers with brimonidine and dorzolamide and brimonidine and dorzolamide and timolol. So these are the various combinations which can be kept at your Viva table. It is not only single drug will be kept. The other systemic drugs which can be used for glaucoma are hyperosmotic agent. This increases the plasma osmolarity, which ultimately draws water out from the vitreous cavity, thus by causing shrinkage of the vitreous volume and decrease in the IOP. It is most commonly used as a immediate treatment for patients with acute attack of angle closure glaucoma. And secondary, if there is an intraoperative raised IOP, so we can also use these as intraoperative measures to decrease the intraocular pressure. The commonly used is the mannitol, which is available as a 20% solution in the dose of 1 to 2 gram per kilogram body weight. It is to be given IV at a fast rate, because if you give slowly it will get diluted by the blood, so there will not be an osmotic effect and the IOP will not get down. The side effect of this is hypervolemia. So it is contraindicated in patients with uncontrolled hypertension, congestive heart failure or decreased renal output. It can be given in the diabetic patients because it is not metabolized, but glycerol, which is available as an oral solution, it is contraindicated in patients with a diabetes. The dose of glycerol is 30 ml 3 times a day. So 30 ml glycerol and 30 ml lime water, and patient has to drink it orally. The side effect, because it is very viscous solution, it can cause nausea and GI discomfort. So these are the drugs. This is a dorzolamide. This is a combination of ripasudil and timolol. This is ripasudil alone. This is brimonidine and timolol, alone timolol, brimonidine timolol combination, and travoprost and bimatoprost. The third group of drugs are antibacterial agents. So these are usually used in most common in any infective conditions like conjunctivitis, corneal ulcers, acute dacryocystitis, endophthalmitis, panophthalmitis, and the most common one is for preoperative prophylaxis and post-operative treatment. So the agents are gentamicin, tobramycin. Depending on the intensity of the infection, the dosage can be from 1 hourly, 2 hourly to 4 times a day or even twice a day. Usually the side effect of gentamicin is majority of antibiotic gives burning and irritation sensation to the eyes, and gentamicin is contraindicated in pregnant female and child. Tobramycin can be safely used in pediatric age group. The other ones are ciprofloxacin and fluoroquinolone group of drugs. Ciprofloxacin and ofloxacin, moxifloxacin, levofloxacin and becifloxacin and getifloxacin, all drugs are available and the uses are more or less same. Azithromycin is available as a 1% ointment as well as drops. Previously the most common use for azithromycin was for trachoma infection, but it has now been eradicated from the India. More commonly used antibiotic for preoperative and postoperative prophylaxis against infection is a moxifloxacin and gefloxacin nowadays. So antibiotic alone, and it also comes with the combination. It can come with in combination with ketorolac and with the steroid also. So if antibiotic and strong steroid is there, it is used as an postoperative treatment, and if it is along with a mild steroid, it can be used in allergic conditions. So next one are steroids. Various types of steroids which we can group as a potent steroids and low potent steroids. So potents are prednisolone acetate and dexamethasone and difluprednate, and lower ones are fluorometholone and loteprednolol. The most common use of steroid is post-operative, so post-cataract surgery, post-glaucoma surgery, post-retinal surgery, post-squint surgery. So any post-operative period, because surgery itself is an inflammatory condition, so to decrease the inflammation we have to give steroids in the post-operative patients. Apart from the post-operative patients, the second major indication is uveitis, where we have to give steroids according to severity of uveitis, starting from 1 hourly to 4 times a day if there is anterior uveitis. If there is a pan uveitis, we have to give systemic steroids in form of intravenous methylprednisolone pulse therapy, or sometimes as a subtenon steroid injections also. It can also be used in patients with the chemical injury. Steroids are indicated in patients with the chemical injury and in patients with the optic neuritis. So prednisolone usually is available as a 1% suspension, dexamethasone 0.1, and the low potent steroids are fluorometholone and loteprednolol, which are commonly used in patients with allergic conjunctivitis, in patients with adenoviral conjunctivitis and keratitis. So prednisolone is anti-inflammatory, anti-allergic, anti-fibrotic. Use as already been mentioned, it is uveitis, scleritis, allergic conjunctivitis, keratitis, in cystoid macular edema and any after intraocular surgeries. So the side effect of topical steroids are it can cause cataract, glaucoma, aggravation of dry eye, and in some patients ptosis. So whenever patient is having vernal keratoconjunctivitis, once we usually prescribe steroids, soft steroid or prednisolone, allergy goes. So majority of patients have tendency to self-use these steroids over a long term. So in our practice we have seen many patients who are using steroid drops since 4, 5, 6 years, and they come to us with glaucomatous optic atrophy. So steroid has to be used very cautiously in patients with the allergy. The next group are NSAIDs, that is non-steroidal anti-inflammatory drugs. I'll be speaking only about the topical one. So we used our flurbiprofen, ketorolac, bromfenac and nepafenac. So flurbiprofen, which is 0.3%. Nowadays the use only remains to maintain the preoperative. It is used preoperatively just to sustain the dilatation of the pupil during the surgery. Which surgery requires dilatation of pupil? Cataract surgery, then any retina surgery, right? So to sustain the dilatation, we require only use of that is in flurbiprofen. The second one is ketorolac, which is used in patients with allergic conjunctivitis. As you have seen in previous slides, it is also available with the combination of antibiotics also, just to prevent the secondary infections. The bromfenac and nepafenac, the benefit of these two drugs, it has a more of a posterior segment penetration. So it is most commonly used in patients with cystoid macular edema or diabetic macular edema, in uveitis, episcleritis and scleritis, where we require more of a posterior penetration of the drug. The side effect of NSAID is it can cause corneal toxicity and cornea verticillata, more common with the bromfenac and nepafenac, and it loosens up the corneal epithelial junctions. The anti-allergic drugs, commonly used are cromolyn, sodium, which is mast cell stabilizer, olopatadine, bipotastine and alcaftadine, which are H1 receptor inhibitors, and these are used as allergic conjunctivitis more commonly in the patients with the vernal keratoconjunctivitis. Olopatadine effects usually starts after a week, so it is more commonly used as a prophylaxis to prevent the acute attack of VKC. And alcaftadine and bipotastine, the mechanism immediately after the instillation of drops. The next one are antifungal agents. These are the netamycin, most common used are netamycin, which is used as a 5% and it is always comes in the suspension. So we have to instruct patient to shake the bottle well before instillation of netamycin. The side effect is because it is a suspension, it gets precipitated and the matting of lashes can occur, otherwise no side effects. And these antifungal agents are used for fungal keratitis and fungal endophthalmitis. Amphotericin B, we have to prepare it for the topical purpose, otherwise in systemically we can give in patients with the mucormycosis, and there are so much systemic side effect of IV amphotericin, which includes hypokalemia and infusion related toxicities. Other commonly used antifungal is a fluconazole, which is available as a topical 1 to 2% as well as an oral tablets in form of 150 to 200 milligram. The drawback of systemic fluconazole is an allergic rash. It is a teratogenic, and because the fungal corneal ulcer are very resilient to the treatment, we might have to give fluconazole for a month or two. So we prefer, because it has a liver toxicity, we prefer to do liver function test before starting the fluconazole and after 3 weeks, so that we can rule out any liver toxicity. The newer antifungal agent we use is a voriconazole, which is a very potent drug, and it has to be prepared freshly, and it is commonly used for the aspergillus fungal corneal ulcer. So these are various antifungal drugs. Fluconazole, Vozole is a voriconazole, which is a 1%, and netamycin. The next one is antiviral. Topical available are ganciclovir 0.15% ointment and acyclovir 3%. The dose of acyclovir is 5 times a day, ganciclovir is 3 times a day. It blocks the viral replication by acting on mRNA. The use of this is in all types of viral keratitis patients, like epithelial and stromal keratitis, more common with the herpes simplex. Post penetrating keratoplasty, whenever patient is having an herpetic keratitis and there is corneal scar and that patient undergoes a graft, there are high chances of recurrence. So we can use in that type of patients, and it can also be used to reduce ocular complications of herpes zoster ophthalmicus. And systemic antiviral like systemic ganciclovir or valacyclovir can also be used in patients with the CMV retinitis and in patients having herpes zoster. Can anyone tell me the nerve supply of cornea? Why there is recurrence of viral keratitis? It is which nerve? Trigeminal. Which are other nerves comes in eye, in around eye? Optic is which number? Second. Then third is oculomotor. Fourth is, fifth is, okay. Then which is the most sensitive part of body? Cornea, highly innervated structure, right? The next one, and I think most of you have been using these drops, are lubricating drops. How many of you have undergone LASIK surgery or any type of refractive surgery? No one? That's great. The use of this, there are various types of artificial tear substitutes available. One is carboxymethyl cellulose, which is available as 0.5 and 1%, polyvinyl alcohol and its derivatives, and sodium hyaluronate. So the most common use are for dry eye, for post-refractive surgery, for any post-operative patients where there is an ocular surface abnormalities, in patients with computer vision syndrome, in patients with SJS where there are various components of dry eye. And these act as a tear substitutes. Majority of these acts on the, how many layers of tear film? 3. Which one? The basal layer is nearest to the eye is mucin layer secreted by goblet cells. The second layer is aqueous layer which is secreted by lacrimal gland or accessory lacrimal glands. So majority of secretion comes from accessory lacrimal glands, and the outermost layer is lipid layer secreted by meibomian glands, right? So majority of these lubricant drops acts on the, it act as an aqueous substitute, right? So these are about the extraocular drugs. Now we will move into the intraocular drugs which are commonly used. One is the viscoelastic substances. It may be hydroxymethyl cellulose, sodium hyaluronate or chondroitin sulfate. It is used to maintain the anterior chamber during intraocular surgeries to replace the aqueous, right? Can anyone tell me what types of cataract surgery you know? I cannot hear anything. It is, what is full form of ECCE? ICCE? What is difference? In which surgery we remove anterior posterior capsule along with the lens? Great. So whenever we are doing any cataract surgery or any keratoplasty surgery or any intraocular surgery, where once we keep incision on the cornea, the aqueous will leak because it is a liquid, very liquid structure. So we have to replace the aqueous, otherwise we will be damaging the corneal endothelium, lens, posterior capsule or any other major structures. So these viscoelastic substances are thick in viscosity, so it coats the endothelium and prevents any injuries. It can also be used to coat the IOL while implanting the intraocular pressure. And it also prevents entry of blood and any other fluid into the anterior chamber. The other commonly used things which can be kept on the table is a fluorescein strip. It is used for the corneal staining to detect the corneal abrasion, ulcer. It can also be used to check wherever there is wound leak or not, like in a Seidel test, for applanation tonometry. For T-butt, what is T-butt? T-butt is tear film breakup time. In patients with the shallow anterior chamber where we feel there is a wound leak, in patients with the perforating injuries, so we have to check whether the entry is closed or not. The drawback of fluorescein is it has potential to grow a Pseudomonas infection. So nowadays we usually strip only. Previously the solution was also available. The another one common as anesthetic agents. One is a proparacaine, which is procaine, which is used as 0.5% eye drops. The most common use as a nowadays because the surgery, please quiet. Surgery is done under topical anesthesia. So for topical cataract surgery, whenever we have to remove any corneal or conjunctival foreign body, so we need a surface anesthesia. For concretions removal, for taking applanation tonometry or Schwartz tonometry. The another one used is injection lignocaine and bupivacaine. Lignocaine is a short acting agent. The action starts in 5 minutes and peaks at 25 to 30 minutes, and maximum it lasts for 1 to 2 hours. And bupivacaine action starts after 30 minutes, but it lasts up to 4 to 6 hours. So whenever we want to give any peribulbar anesthesia nowadays, we prefer the combination because we need immediate local anesthesia as well as a prolonged one. So lignocaine is 2% and bupivacaine is 0.5%, and we usually instill hyaluronidase because it increases the tissue penetration and it also same time decreases the systemic absorption. So it is used as a local anesthesia. The type of block commonly used is a peribulbar anesthesia, but previously retrobulbar block was also given. Nowadays retrobulbar block is only given in patients with a mucormycosis, where we give retrobulbar amphotericin, or in patients with methyl alcohol amblyopia, where we give retrobulbar dexamethasone. Otherwise majority of surgery are done under peribulbar anesthesia or topical anesthesia. I think last few are intraocular irrigating solutions. Ringer lactate or balanced salt solution is used, which is used to replace the aqueous in the cataract surgery, anti-glaucoma surgery, keratoplasty surgery, or in a vitreous surgery. I think Maddox wing is used to determine the size of deviation. Red-green glasses sometimes may be kept on the table for the diplopia charting, and prism bar to find out the amount of deviation in the squint patients. Any questions? If you cannot ask any questions, we have many questions to ask in Viva. So if any query, please feel free, because we are here for you to solve your query. Yes, please. Squint, you just need to remember that what is exotropia. Exotropia is an outward deviation and esotropia is an inward deviation, and you have to remember the nerve supply and origin insertion of all extraocular muscles. That is, at least these things we wish you are supposed to know. All the best.
We are thankful to all the faculties who were available on a very short notice to guide you all students on the behalf of Ahmedabad Medical Association. Now I request Dr. Jignesh Shah, our president, to come and felicitate the men with memento. Memento liya. Kalpita men, आओ. मलिक भाई आओ. છોકરા 5 મિનિટ બેસી જાઓ બધા, અને પછી બધા માટે હાઈટી અને બિસ્કિટ ને બધું છે એ લઈને પછી ઘરે જજો. ઉતાવળ ના કરતા, એક્ઝામમાં વાર છે. કોઈને ઇન્સ્ટ્રુમેન્ટ જોવાનું હોય તો અહીં આવીને જોઈ શકે છે.
2 મિનિટ માટે, એક્સક્યુઝ મી, ત્રણેય મેડમે ખૂબ મહેનત કરી છે. એકવાર તાળીઓ બધા માટે, તમારા રિવિઝન માટે, ટીમ એએમ એન્ડ ઓલ. સેકન્ડ 2 મિનિટ માટે બેસજો. જેમ અમદાવાદ મેડિકલ એસોસિએશને બહુ જ આમાં કામ કર્યું છે, એ રીતે તમારા દરેક કોલેજમાં આઈએમએ મેડિકલ સ્ટુડન્ટ નેટવર્ક ચાલે છે, MSN. તો બી એ પાર્ટ ઓફ ઇટ, અને ઘણી બધી એક્ટિવિટી કરે છે, તો યુ વિલ ગેટ બેનિફિટેડ. પ્લીઝ.